All right. Well, while we're getting assembled here, I just want to give you a little bit of context for the next session coming up. So for the next hour or so, we will be in session B of the platform presentations. And just a reminder, folks, come on in, take your seat. We got plenty of seats up front. We got a couple of empty tables up front as well, so come on up. If you have friends out in the hallway, text them, tweet them, tell them to get back inside. The community engagement posters, that's right. Well, they're putting the engagement in community engagement, so that's a good thing. So the next session was going to be moderated by Matt Swanson. And Matt sends his regrets. I saw him this morning. Unfortunately, he had a death in the family, and he's not going to be able to join us. But I did want to tell you a little bit about Matt's work. Matt is a good friend of mine. We've worked together for the last several years on the State Innovation Model-funded Delaware Center for Health Innovations. Matt started a group called Innovative Schools, and since 2013, he's led that nonprofit. Really helps to contribute to sort of the intellectual underpinnings of educational advocacy in Delaware. Matt is chairman of the Delaware Center for Health Innovations, helping lead forward much of the work around clinical care and health reform in our state. And again, we're sorry that he couldn't join us today, but our thoughts are with him. Dr. Heather Bittner-Fagan, our stalwart from the last session, has kindly agreed to step in to moderate. So she's actually going to take the reins. So we're going to get started right now, and please join me in giving another warm Excel welcome to Dr. Heather Bittner-Fagan.
I'm actually very excited to have the job of moderating this next group of really great presenters. And the first group that we have here actually is equally well known to me. They've done some really cool stuff that I'm excited for you to hear about, which is, this is a group that has long worked with the Delaware Youth Risk Behavioral Surveillance data, which, as you guys know, is really important in understanding and really taking the pulse of youth in terms of their risk behaviors, but has never, as far as we know, anywhere else in the nation, really been sort of thoughtfully adapted to allow children with disabilities to participate. So I'm going to let you hear more about that from Elizabeth DeBruviac, Steve Martin, and Patricia Makeley. Michael. Oh, simple. Michael. Okay.
That's okay. I always end up telling people how to pronounce that name anyway, so no big deal. I'm Patricia Michael. I'm the director of the Developmental Disabilities Council here in Delaware, and I'm here to introduce our next two speakers in this group and to celebrate the work that they have done. I'm very excited about what they have accomplished over the past couple of years. Historically, people with disabilities, it's not changing, okay. There you go. Historically, people with disabilities have found themselves on the outside looking in. They typically, for hundreds and hundreds of years, have not been included. They've not been able to have access to services, the environment, or to their civil rights that they should be able to enjoy. And the same was true for, unfortunately, the risk surveys that we do here in Delaware. And for about 5 to 6 years, in collaboration with the Victims' Rights Task Force here in Delaware, which includes victim advocates from across the state, the Developmental Disabilities Council has been advocating often, regularly, repeatedly, to allow for students with disabilities to be able to be part of these risk surveys. They have not been included. They were strategically not included since the beginning of the surveys began. And I'll tell you a few statistics that gave us the reason why we continuously and without end advocated for these kids to be included. In a recent report from the Bureau of Justice Statistics with the U.S. Department of Justice, in 2014, the rate of violent victimization against persons with disabilities was 2.5 times higher than the age-adjusted rate for persons without disabilities. Every year between 2009 and 2014, the rate of violent victimization against persons with disabilities was at least twice that for persons without disabilities. Serious violent crime, which includes rape or sexual assault, robbery, and aggravated assault, accounted for a greater percentage of violence against persons with disabilities than violence against persons without disabilities. The rate of serious violent crime for persons with disabilities was more than 3 times the rate of persons without disabilities. Persons aged 12 to 15 had the highest rates of violent victimization among those with disabilities, except for the persons aged 16 to 19. In 2010 to 14, persons with cognitive disabilities had the highest rates of total violent crime, serious violent crime, and simple assault among the disability types measured. These are just a few of the statistics that are in this report, and I hope that you would take a look at that report. It's online. You can find it online with the U.S. Department of Justice. We from the disabilities community and those folks from the victims advocacy community knew these results, knew the outcomes that people have, and know that others in the general public are not aware of the severity of victimization of people with disabilities. So we interacted with these folks who do the work, and they graciously, after knowing that we were not going away, have figured out how to include people with more significant disabilities in at least the survey that you're going to hear about today. They enlisted the help of the Department of Education to figure out what accommodations could be made to keep the integrity of the surveys and the anonymity of the surveys. And they'll talk more about that. Outcomes for students and the public are hopefully that if we're able to use this information that we gather to inform and guide the actions of the state and the federal government, that services will be available to people with disabilities, hopefully before they're victimized, but also in case they are victimized. And this issue, the work that's being done here in Delaware around this issue, is being watched by those across the country. I've shared the information with the other developmental disabilities councils across the country and in the territories, and they are waiting to see what kind of work we do. Unfortunately, this same phenomenon of students not being included is being repeated across the country. So everyone's watching to see these outcomes. Just to quickly give you just one of the graphs that has been gained by doing this work. This is, they're all self-reports. The children who take part in these surveys, it's all self-report of disability. So probably the numbers are higher. But for self-report of physical disability, if you look at the chart on the left, this is just a question about in the past month, how have you used cigarettes or e-cigarettes? And you can see the high percentage of those kids who report that they have a physical disability, the use of cigarettes and e-cigarettes. And then on the right-hand side, self-report of a cognitive disability, a disability which makes it difficult to concentrate, remember, or make decisions. The numbers are just as high amongst that population of students. Just the use of cigarettes and e-cigarettes obviously significantly affects these kids. So that's just one of the charts that these folks will talk about, and I will hand it over to them because they have a lot more to talk about. So thank you very much for hearing us. And I'm going to turn it over to Liz, who's going to speak next.
Hi. Thank you, Pat. I just wanted to say my name is Liz Dobrachich, and I'm with the Division of Public Health. And I wanted to thank ACEL and ACE for funding this project. The first thing we did when we got the funding, was to assemble an advisory panel which consisted of community, the disabilities community, school community, our federal funding partner, and technical and subject matter experts, whether at the university or within the school system. And our project team also represents the research community and public health. So our advisory panel was instrumental in all aspects of the research. First of all, drove the research by demanding that we include more students with disabilities in our health surveys. They provided insight on key issues such as accommodations, student engagement, and the educational supports that are out there, the logistics and the data systems. They also were instrumental in identifying pilot sites, designing disability screening questions, and also on occasion helping us to obtain data that may not be forthcoming so easily to the rest of us. Interpreting findings and making recommendations regarding the survey protocol. They were helpful in developing these, and also will be assisting us with disseminating the findings. So our project kind of looks at participation, and here's kind of a slide to frame the project through participation. As I mentioned, we do the Youth Tobacco Survey and Public Health, and also the Youth Risk Behavior Survey. These are population-based surveys that are administered to middle and high school students biannually, so in alternative years. They follow a standard protocol, which was developed in the late 90s, so it's been almost 20 years now. And it is a little bit antiquated in that it basically excludes any students who are in classrooms where more than 50% of students are enrolled in special educational programs. So we undertook to demonstrate that the ability of students to participate in this survey with and without accommodations. The project didn't go quite so far as to focus on students who are not able to participate independently in taking the survey because that might compromise their anonymity. So we leave that research for another project. Okay. So our objectives were to assess the extent and of the current patterns of exclusion and inclusion using the current protocols. We wanted to explore the feasibility of surveying some excluded groups of students using accommodations or not as needed, and to develop recommendations for changes in the health surveys. So I have to hurry up here. We also wanted to develop and pilot a disabilities status indicator, which was not existing in the Youth Tobacco Survey in the past, and to then use that to assess disparities in health risks and outcomes. So just quickly, we looked at a lot of data on enrollments, disability accommodations. We looked at administrative data. We conducted key informant interviews, and we developed an electronic survey. I'll just jump on here with embedded ASL. We also developed a disability status indicator that is 2 items. If you do any kind of surveys, you know that you need to minimize the number of items, so we were tried to be efficient there. And our advisory panel was instrumental in helping us focus that first question on what students use what they rely on to help them do what they need to do. So it's an empowering kind of question rather than asking the disability question. The IEP is another method that we use to find out whether they have a disability, and not all students know whether or not they have an IEP. So we hope that this indicator would give us a balance between the 2 questions. Okay, what we found out is more than 95% of students are actually participating in the sampling protocol. So the yellow section there and the green, which is students who are enrolled in traditional classrooms or standard. The 14% of the students at the high school level have some type of a disability, and of those, that yellow slot, 70% are already participating in the sampling frame. So we were looking at the 2% of students who are in special schools, so they're automatically excluded, as well as the gray area where the students are participating in traditional schools, but they may be excluded from the survey because of the classroom protocol. And what we found out when we used the two indicators was that about 17% of students indicated, all self-reports, that they either had an accommodation or used one of those supports, or they have an IEP. And then when we looked at the data from the survey in part 2, we found that, in fact, the students who have the disabilities that we identified are both more susceptible to use of tobacco and are less likely to understand the dangers of tobacco, and they also use tobacco of all types in greater percentages than students without disabilities. Okay.
I'll take 20 seconds to just say additional steps we're doing. What we found out is more people are being included than we thought to begin with in the YTS. However, their degree of involvement is something we're looking at from the questions we put into the 2016 YTS to see if the students who report disabilities, cognitive or physical, are more likely to finish the surveys and such. But we're also looking at how we can include these specific groups of students who haven't been in the past. We've been disseminating our findings in various ways locally and at national conferences at APHA, the American University Centers for Disabilities, and the National Council on Tobacco and Health. We're moving toward taking the data we have from our large-scale surveys from the YRBS and the YTS, combined with our pilot data in the special schools to put together some papers for peer-reviewed journals. And that's the process so far. And I really appreciate your time and the efforts of the disability community in getting us to do this kind of work. Thank you.
Our next group will speak about instilling the art of happiness in community-dwelling adults. And while I don't know that I've had the pleasure of meeting any of you, I think I know a lot of your names, so it is really nice to be in the room. We have Steve Goodwin, Katie Greenewalt. As the stand-in, I like to really mispronounce at least one person's name up here. Jenny Turner, Vicki Sheridan, and Elizabeth Ortega Smith. Did I? Okay, well, I'll try harder next time. Thank you.
Yeah, hi, thanks. Whoa. So I'm Steve Goodwin, Behavioral Health and Nutrition. Jenny Turner, Katie Greenewalt, our community partner, Vicki Sheridan, and Beth Ortega Smith. So this all came about 30 years ago. I read the book, The Art of Happiness by the Dalai Lama. And I always said, that's a good book, I ought to reread it. About 10 years ago, I reread it. And when I read it this time, I read it through a different lens. And as I was reading it, I just kept saying to myself, this is what we should be teaching our students, this is what we should be teaching people. Because at the heart of it, most positive health behaviors come when we're feeling good about ourselves and are happy. And many of the negative behaviors come when we're not. So at that point in time, I started the Art of Happiness class for the undergraduate population. And I learned from that was in fact happening. So Beth and I talked about the possibility of using this with older adults. And so we did a feasibility study to see if it would in fact translate what we were seeing with the undergrads with older adults living in a community that had access to a community center. And we were really trying then to see, will this impact their overall mental well-being? And specifically, will it increase their subjective happiness, and will it then also possibly have a negative impact on some of the mood disorders that are so common with older adults? So we went to 2 senior centers, and with that we did an 8-week intervention. Now we pared down a 15-week course down to 8 weeks. And we really tried to look and identify which of these topics are most critical for seniors. And we developed an 8-week intervention class, etc. And then we did a pre-post test design, basically just looking at some of these measures, as you can see here: gratitude, life satisfaction, depression, stress, mindfulness, arousal states, and then their overall subjective happiness. Then we also collected some demographic information on them and looked at some of the general health measures to see if it was going to be having an impact. And we, of course, used our senior center. Our directors were very, very helpful. And you can see they aided in recruitment of adults. And then they also assisted us in our communication with them. And they provided support for space, AV, for our sessions that were done. And then our Vicki Sheraton back here was also a participant in the course, so she was really able to bring in an interesting perspective for us as we hopefully will be able to move forward.
So each participant received a book and a journal for weekly reflections. So each class was 90 minutes long, once a week. So we had a lecture on that week's topic, discussion on the homework assignments, as well as the assigned readings from The Art of Happiness, as well as activities relating to the weekly topics. And in the corner there, you see, that was our stress management week, and we had therapy puppies come to the class. So it was a lot of fun. And then again, discussions on the related homework assignments. So we tried to keep things fun and upbeat. So these are the topics throughout the 8-week session. So we have defining happiness, stress management, reflecting on happiness, compassion and human connection, forgiveness, transforming suffering, mindfulness, and then we closed it out with humor. And this is just a picture of, there's me in the front, as well as the undergraduate student who assisted in the class lectures, Erica Rathy. She's not here today. But that's at Howard Weston during the stress management week. And then here we have an example of one of the homework assignments. So this was a lot of fun. It was a photo voice activity where throughout the week, they were all given a camera. So throughout the week, they all took photos of things that made them happy. And then we posted them up on the poster boards, and they wrote why they made them happy. So everyone really enjoyed seeing how happiness was subjective and really relating to each other in terms of their own happiness.
So we actually, again, as Dr. Goodwin had mentioned, we did a pre-post study and kind of looking at what the participants were. We had about 34 participants, and most of them were married. It was a predominantly female population, white, and the age range spanned from about 53 to 93 years of age, with a mean of about 74. In addition, most of the population had about a little bit over a high school degree. And that's kind of indicative and similar to what we see at a variety of the different senior centers in the state of Delaware. And whenever we looked at the health problems, we found out that about half of them, again, this is based on self-report, considered themselves to be either overweight or obese. About 15% were diabetic. We saw a large majority had indicated that they had hypertension and high cholesterol, and then about half had just said that they had some other type of health issues. And again, those health problems are, again, very similar to what you would see in a population of older adults. So these results are based on a paired t-test. So we did, again, the pre-post, and we found that looking at the primary aim of our study, that we saw significant increases in the subjective happiness scores. Additionally, when we also looked at some of the other positive mental health indices of satisfaction with life and also mindfulness, we noted that those scores also improved. Whenever we looked at some of the negative health indicators such as depression, and we looked at the mood states, and in particular found that tension and tiredness scores, those decreased, which meant they had an improvement. Just as a little aside too, we did look and collected data on a small sample of a control population, and we found out that there were these significant differences did remain whenever we did control for the baseline levels and did a comparison between the actual intervention group and then again, it was an unmatched control.
So we had the chance to kind of talk to some of the participants who took the class afterwards. We used a random selection of participants and did some interviews. And up here we have a quote from one of the participants. And this person said, "I'm more aware that I can manage my feelings by taking time to recognize them, assess them, and deal with them. I also find myself appreciating more of the little daily things that make me happy instead of waiting for the big events." So talking to these participants, we really were able to confirm our results from the surveys that they were experiencing improvements in their subjective happiness. Additionally, we were able to interview the senior center directors just to kind of see what they personally saw as an impact on the centers as a whole and on the seniors who took the class. So this up here is a quote by Beverly McCool, who is the director of Claymore Senior Center. She's not here today. And she said that she has personally seen at least 2 from the class that come to the center on a regular basis. She didn't want to say names. That seem to be just more upbeat about life, less critical of other people, and in general, just a little bit happier. And another quote from her about the impact on the center as a whole. She stated that personally for her, the feedback she has been getting from members of the senior center, as far as the positives, is that basically she is looking to seek out more programs that have a focus on mental health. So this program and the feedback she's been getting has really made her more aware of the need for programs like the Art of Happiness in the older adult population. I'm going to pass it off to Vicki.
Thank you. As it was stated before, I was very fortunate to have the opportunity to actually take the Art of Happiness class with my seniors at the center. And rather than read through, because you guys can read my quotes that are on the board, I just wanted to touch on a couple specific things that happened at my senior center. One notably, I had a participant who reconnected with her sister after 35 years, which was a specific result of a forgiveness letter that she wrote during one of the classes. Personally, one of the questions that we were asked was we had to pick an event, a big event, or an event that was something that was going to be exciting for us that particular day. And our classes met on Wednesday, and I was thinking, man, I wish we were meeting on Friday because we were having what we called our senior prom that Friday. I thought, that's a really cool event. I would have loved to have been able to go, okay, this is my exciting opportunity for this day. And one of the other members in the class, one of my seniors, put it in perspective, and I came up with, something that specific day. But one of them came in and she said, I sat down this morning, and when I got out my cup of tea, I thought about the Art of Happiness class, and I thought about how great is it that I can sit here and just relax and enjoy this cup of tea. And that was her happy moment for that day. And I thought, if we could only all take those little moments, a cup of tea, a quick conversation with a friend, and make that our big moment for the day. It doesn't have to be something significant that we're doing. It doesn't have to be a senior prom or, a big convention or something. It can be those little things that we can see the happiness in those. So that's had a big impact on myself personally and the members of our center. I guess I have to push this button too. Sorry. The one thing that is significant in our senior center is that the class has reached further than just those that took the class at the center. It's been kind of neat to watch
the members that took the class, might be in the dining room and somebody took their seat or whatever, and they'll go, does it really matter? Sit with somebody else, make a new friend. And these are the kind of things that I'm seeing from the members that took the class, that they're, as I put in my previous quote, like tentacles. They're spreading out. They're taking this little bit of happiness they got in this class and spreading it to others. So as an end, I'd say, it's just been a wonderful program. I'm so happy to have been a part of it, and we're hoping that they'll come back and do it again.
So the overall conclusion of this study was basically we found out that by partnering with these local senior centers, and just to add as a caveat, these were senior centers in which we have already been doing numerous programs over the past couple summers, so it was an existing partnership. But we found that offering this type of course can impact the overall quality of life of the participants and maybe even the center itself, and also the positive mental well-being of older adults. And kind of our next steps and what we're hoping to do is to create an evidence-based program that can be implemented in a variety of different settings, senior centers both in rural and also urban, suburban areas, but in addition to see how we can actually modify or adapt this program so it can be implemented in other settings such as either assisted livings or long-term care facilities. So thank you very much for your time. One other note I do want to mention is that this was actually carried out by both Katie and Jenny, great graduate students, and we also had a very mature undergraduate student who's taking her GREs right now. And so they were actually doing independent studies to actually carry out these programs. So thank you.
I think this is a great project. Doesn't take a geriatrician to recognize that. I'm always telling my patients they need to go to the senior centers. They're wonderful places who do wonderful things, so thank you for that. My question was, has anybody looked into what percentage of your patients had maybe mild cognitive impairment or dementia, maybe mild versions of that? I don't know if it would change the intervention, but it would be an interesting thought, an interesting population who could really benefit from this as well.
So we did not actually look to see if they had, or we didn't use a screening tool to assess whether or not they had mild cognitive impairment. One of the qualifying, whenever we asked for people to participate, was that they didn't have any cognitive impairment, but we did not assess that.
I agree. Wonderful stuff you're doing. I wonder if it would be useful to inform, you may do this, visitors, family and friends who may be coming to visit the residents about the course that you're teaching them and helping them to understand the rationale and the basis to kind of reinforce that and maybe strengthen and even bolster this kind of changed attitude.
Again, this was conducted in a senior center, so for some of those individuals that may not necessarily know a senior center, and Vicki could probably answer this better, but a senior center is basically a community center for older adults, so people do not reside there. They come and go just as we would come and go to a recreation center. So that may be, again, kind of thinking about the next steps if we are able to adopt this program for something like an assisted living or long-term care facility. That was definitely a good consideration.
Well, thank you very much for this great program. How did you recruit the patients, the people, not patients, but the people who wanted to participate in the program?
So we recruited participants. Me and Katie attended various senior center events, and we kind of, through word of mouth as well as flyers, the directors talking to the senior center attendees, so really just word of mouth, that sort of thing.
And next we have Dr. Erica Sood, who's going to talk to us about an innovative model of family psychosocial care for congenital heart disease.
Hello, I am Erica Sood. I'm a pediatric psychologist in the Nemours Cardiac Center, and I'm also an Excel pilot grant recipient, and I'm going to be talking today about my current pilot grant titled Family Psychosocial Care Model for Congenital Heart Disease, a crowdsourced study. Apparently I pushed the wrong button. Got it. Okay, so this study aims to apply online crowdsourcing to the development of a psychosocial care model for families of infants with congenital heart disease, which could prevent parental traumatic stress and ultimately improve child outcomes. And it's my hope that in the long term, this can also help to inform formal psychosocial standards for congenital heart disease. And this study started in December 2016, so we're a few months into the project. My mentor for the project is Dr. Ann Kazak. We have collaborators from MUSC and UD. We also have 4 community collaborators, and these are folks in leadership roles of 4 national congenital heart disease community organizations that provide parent-to-parent support and education, as well as advocacy around CHD. And unfortunately, I'm up here alone today because 3 of them are in the Midwest, 1 of them's on the West Coast, so they're with me in spirit. We also have clinician collaborators from a few different institutions, so CSU nurses, palliative care physicians, social work, psychologists, advanced practice nurses from institutions including MUSC and Nemours. So I'm going to start with a rationale of the study, and then I'm going to do a brief overview of study methodology, and then I'll finish up with the role of the community collaborators on this project and the high level of community engagement that we've seen so far. So for those of you not familiar with congenital heart disease, it's the most common birth defect. It impacts about close to 1% of live births, and about 25% of these have a complex form that requires intervention during infancy. And this experience is quite challenging for families. So in many cases, the diagnosis is made at birth. The mother remains at the birth hospital while the baby's often flown to a children's hospital, which could be in a different state hours away. And there are many disruptions in normative parent-infant bonding. So in some cases, parents aren't able to hold or even touch their baby for weeks, days or weeks. And parents are often far from home, from their support networks, from their other kids. And as you can see from this photo, this is actually Jimmy Kimmel's son, which went viral on the internet a couple weeks ago. You probably all remember when his son was diagnosed with tetralogy of Fallot, which is a congenital heart defect. Just the image of a child with CHD in the ICU can be very intimidating. And this is what parents see of their newborn baby. So we know that parents are at higher risk for parenting stress, anxiety and depression, poor quality of life, and that approximately 1/3 report clinically significant symptoms of traumatic stress, and that parents who are experiencing anxiety and depression and traumatic stress have children with more difficulties later on with regards to emotions and behavior and quality of life. So if parents and families are not doing well, generally kids are not doing well. And unfortunately, in congenital heart disease, we don't have any formal standards for how to support families in the hospital, in the community, in clinic, unlike other patient populations like pediatric cancer or the NICU setting, where they have special issues dedicated to this topic. And as a result, there's a lot of variability and sometimes just absence in psychosocial support for families across centers, within centers, and in communities. So it's necessary at this point to identify a model of psychosocial care that's both acceptable and feasible to all stakeholders. And there's a lot of stakeholders who are involved in the care of children with congenital heart disease. They're quite complicated and require a lot of care from multiple providers. So, I feel that this requires interprofessional and community collaboration. In this project, we are going to be working with approximately 100 parents, 50 healthcare providers of different disciplines, and about 20 leaders of congenital heart disease organizations. So the first aim is to identify stakeholder crowd perspectives, and I'll talk a little bit more about crowdsourcing in a minute, on best practices and barriers to promoting key domains of family-based psychosocial care. So we identified as a team 9 domains that we felt were potentially important when thinking about family psychosocial care for congenital heart disease, and we're asking questions to our stakeholder groups within all of these domains. And certainly we could add to this or take away, based on what our stakeholders are saying. And then we're going to be incorporating the knowledge, experience, and perspectives that we gain in AIM 1 to develop a family-based psychosocial care model for congenital heart disease and refine this model with stakeholder crowd input. So Many of you may be familiar with crowdsourcing. It refers to the process of generating ideas, solving problems, and producing results by soliciting contributions from large groups, typically in the form of online communities. It's been used previously to develop a psychosocial support resource by Dr. Tim Wysocki and Jesse Pierce, who are Nemours researchers in Florida. And actually, Jesse Pierce presented at this meeting last year, so some of you may have seen that presentation. And it allows for participation from folks nationally, and also allows folks to give feedback on the iterative development of the model. So not just one-time participation, thanks for the information, see you later, but really our participants are participating over the course of a year, not only to answer our questions, but then to give us feedback on the model as it's developed. We're using Yammer, which is a private social networking site. Similar to Facebook, it looks pretty similar. It's used more by professional organizations. We invite all of our participants to join the CHD Family Support Network, and then they're added to individual private groups for their particular crowd. So parents are in one group, healthcare providers in a group, community leaders in a group. And then we pose questions, they respond, they can see each other's responses, there can be dialogue between participants. We've been posting 3 to 5 queries about every 2 weeks, and participants have a week to respond. Each set of queries focuses on one domain of family-based psychosocial care, and then the responses become qualitative data that are coded and analyzed for common themes. And then themes from the past queries inform future queries. So we've already made a lot of edits to the questions that we plan to ask based on what we're hearing from participants. We have, as I mentioned before, community collaborators as well as clinician collaborators, and we have twice monthly conference calls. And our collaborators are very involved in making decisions from the very beginning. They've made decisions about study methodology, helped to advise our recruitment strategy. They've done a lot to just generate enthusiasm about the study in the CHD community. They're the ones that actually disseminated the information about the study with the link for families to sign up. And I'll talk a little bit more about that. They've helped us to refine the study questions. So really every aspect of the study they've been involved with. We started recruitment of our community leader crowd in February. There was a lot of pre-recruitment work that went into this, of networking, emailing back and forth with community leaders, phone calls with leaders, and then the leaders are actually the one that spread the word about the study to their board, and we hit our target enrollment. We actually exceeded our target enrollment in 72 hours. And we've posted 20 queries so far, and the majority of them have very good response rates. So 75% or more leaders have responded to each question except for 2 of them. And we've already seen that this study has led to change. And I think this is something that I've learned about the importance and power of community engaged research is you don't see that same gap of 17 years between when a result is published and when it goes into practice. So based on even the few months into this, leaders are reaching out to us and saying, can you do a webinar on this? Or our members are asking more for this information. So we've done webinars that have been the most highly registered webinars from that organization on parent mental health. With CHD, we've done, we're going to be writing a practitioner's post, and this is collaborations again between the clinicians, the researchers, and the clinical collaborators and community collaborators. And then we just started our recruitment of the parent crowd. And with this, we actually used a pre-enrollment survey so as not to fill up very quickly with a homogeneous sample. So we wanted a lot of diversity, obviously. So we had individuals who were interested fill out a pre-enrollment survey with demographic and clinical information and their email address. We had 117 parents complete the survey in the first 12 hours, 234 over 1 week. And then of these 234, we invited 135 parents that represented diversity. So a lot of interest. We had to turn people away. People were quite excited about it. And this is just a page I wanted to show from Yammer. We haven't even started posting questions to our parent crowd yet, but even just the post that I put about thanks for signing up for Yammer, and we're going to have you join the parent crowd. We've gotten, I think, 23 parents have liked this, and others have written comments like, thank you for this opportunity. We're so excited to be involved in this. So again, reflecting the engagement in the community on this topic. In terms of next steps, we're going to continue data collection from the community leader crowd, begin data collection with the parent crowd. We haven't started recruitment of the healthcare provider crowd yet, and we need to think about which providers we need to hear from. So we're waiting until we know more about what the parents are saying that they need. We're going to be working with our community leaders on a collaborative grant application, and then continue to educate the community through webinars, blog posts, community presentations. So, even before we've published, I think we can really give back and educate the community. So, thank you very much. Any questions?
Thanks. Very interesting study. I'm just wondering if there's any other ways you might complement the internet-intensive crowdsourcing approaches for people who you may not be accessing that way. Are there other technically crowdsourcing methods that don't rely on the internet, I guess is the question.
So I'm not sure about whether it would be called crowdsourcing, but we do have plans once we complete the questions with our crowd, we're then going to do either a smaller focus group or individual interviews, or maybe even paper and pencil. We'll have to figure out what the best methodology is to reach those groups that we weren't able to access through the online crowdsourcing. And the reason we're going to do it later is that we're kind of changing the questions as we go along, and we want to make sure that that group gets the same questions as the other crowd. So absolutely, I mean, literacy is an issue, access to internet is an issue. People can use a smartphone, they can use a tablet, but they do need to have some access to either a smartphone or the internet to participate.
Thanks for that. Will you be asking about psychosocial concerns for the children, like that parents have for their children, or is this mostly just focused on parents?
So this is mostly focused on infancy. So primarily in this study, we're going to be talking about supporting families of babies. And the reason, I mean, is not more or less important. They're both important. But really to start, we thought we'd start there and then move on towards how do we then support children as they're growing up. But we know that if parents are not doing well, their kids are not going to do as well. Nope. So most of these kids have surgery very early. Most are admitted to the CICU right from birth. So our sample, which I didn't mention, is parents. When we're talking about the parent sample, it's parents of children who are now between 1 and 6 years of age, or if the child has died, who was born 1 to 6 years ago. And so we're really focusing on parents who have a young child and can look back on that first year. Thank you.
And the fourth of our 4 panelists will talk to us about understanding the community needs in Wilmington and Claymont, a place near and dear to my own heart. We have Alexa Meinhardt, Jacqueline Natalone, Maggie Nora Spent, and Mia Pappas.
Good morning still, I guess, and thank you for being here as we talk about our project entitled Understanding Community Needs in Wilmington and Claymont, Delaware. And so before we begin, I'd just like to take a minute to acknowledge everyone who has helped us on this project. And then also, before we begin, I would just like to provide some pictures from the community that we have conducted a majority of our work in. And this is just because when we often talk about a lot of the problems in Wilmington, and we forget about the positive aspects of this community, such as how strong this community is in aspects of social cohesion, and that people actually live here, and it's not all just about the numbers sometimes, so just something to provide a reminder of. And then some background. So Delaware, we spend more per capita on healthcare than the United States average. However, health problems still persist. Delaware remains below United States average for many indicators. And significant disparities also exist within communities, and we'll get more into this later, but specifically when we talk about Wilmington, we see disparities within the community itself. So there are zip codes with higher indicators, zip codes with significantly lower indicators, and
So we engage in the Healthy Neighborhoods Project, which is a collaboration spearheaded by the Delaware Center for Health Innovation, and it seeks to target major health concerns and improve health outcomes at the community level throughout Delaware. It's supported by various grants, namely the Center for Medicare and Medicaid and State Innovation Model grants. And so through this project, the state of Delaware has been broken down into 10 healthy communities, each with a population of roughly 100,000. And as we mentioned before, the target area for this study is the Wilmington-Claymont neighborhood located in northern Delaware. Healthy Neighborhoods Framework has provided sort of a council for every community, so they're community stakeholders or different community players that will oversee the progress and help direct future efforts, initiatives, and funding, sort of based off of the research that is found for these neighborhoods. And there are 4 priority areas: maternal and child health, chronic disease prevention and management, healthy lifestyle, and mental health and addiction.
So the Healthy Neighborhoods Project also aims to target the social determinants of health, which when we talk about these, we speak about conditions outside of the medical setting that influence an individual's health status, such as educational attainment or neighborhood and the built environment. So this framework is really built into the Healthy Neighborhoods approach. And specifically, this project was a community needs assessment that contributed to the Healthy Neighborhoods Project in Wilmington and Claymont. So it was guided by the pre-seed proceed model, and our needs assessment focused on the first 4 phases of this model. So identifying the problem, collecting indicators, assessing environmental factors, and identifying program focus. And then eventually the project hopes to develop through the rest of the phases, and really we would implement programs and allocate resources to major areas of concern.
So with this in mind, we developed 2 research questions. First, how can a community needs assessment focus on the social determinants of health, inform community health efforts? And we really wanted to understand where those specific community needs were in Wilmington and Claymont. As Jackie talked about, there are significant health disparities that exist in this region, and we wanted to first identify what they were, and then also sort of see what those, sort of zip code level disparities were. And our study population was residents in 5 zip codes: 19801, 19802, 19804, 19805, and 19703.
So the first part of our framework was to create this resource library, which was determined by the Delaware Center for Health Innovation, and there were 2 components, so a program database and a community profile, which contained relevant health indicators for Wilmington and Claymont, and the database contained health promotion programs, categories, themes where you could access them. And this is a sample page from the 19805 demographic profile. As you can see, there are a variety of different health indicators pertinent to either the social determinants of health or there also are programs here as well. So these are the categories of health promotion programs that are accessible specifically in this zip code.
We also focus on corner store evaluations, knowing that access to healthy food is limited in underserved communities, while also recognizing that corner stores are central in Wilmington and Claymont, and so in addition to being a place to buy food or other household products, they're sort of a social gathering area for residents of these communities. And we use a tool developed by MBA students at the University of Delaware, and it highlighted several criteria, including store exterior, non-food, inventory, and store layout. And this was a convenience sample of 13 corner stores in the 19805 zip code in the city of Wilmington. We also developed a community survey, which was intended to gain insight on community members' perceptions of program availability, need, and usage. And it was developed specifically for the context of this project. There were approximately 100 surveys administered to adults in the city of Wilmington at a handful of different sites, and then 59 surveys were actually completed. And it was a one-page survey with about 10 questions, half focused on demographic questions such as zip code, age, gender, and then the other half focused on, again, those perceptions. So looking at program need, availability, usage, and then perceptions related to travel and other similar themes. Okay, sorry. So moving on to our results. As we mentioned earlier, the resource library provides a strong framework for making those quick comparisons. So we chose 5 relevant indicators: population, income, and then percent of individuals below the poverty level, those who are unemployed, and percent of individuals who are uninsured, and arrange them in order of increasing income. So you can see that 1,801 is the lowest, 1,804 is the highest. And we found that income and unemployment were related to each other, such that individuals with higher household income tended to have lower rates of unemployment and vice versa. And the intent of the community needs assessment was to sort of compare the zip codes to each other, but also to Wilmington and Claymont as a whole. So we highlighted the different zip codes in terms of how they related to Wilmington-Claymont. So 19801 and 19802 had lower income and higher rates of unemployment compared to the whole region. 19805 was similar, and then 19703 and 19804 actually had higher income and lower rates of unemployment compared to that entire neighborhood. And then you can see there's a breakdown of all the programs available by theme as we identified through searching through databases and a Google search. And you can see, I just want to highlight that chronic disease prevention and management programs and programs related to healthy lifestyle had the 2 greatest levels of availability compared to all the other program themes.
So in terms of the corner store evaluations, just a few things that we wanted to highlight were that SNAP was only accepted in 50% of the stores, and of those stores, only 50% sold fresh produce or carried a stock of fresh produce. The average number of fresh produce varieties was 4.31. And a majority of the stores sold tobacco products, and WIC was not accepted in any of the corner stores. So this is significant in terms of options for individuals who are using SNAP or WIC and where they can actually go to purchase food. And then in terms of the community questionnaire results, I'd just like to highlight that a majority of participants reported need in housing, drug and alcohol addiction, and education categories. So this is important when considering community needs and where resources should be allocated in order to improve health outcomes throughout this community.
And then for that community questionnaire that we developed, we found that about 20% of individuals said that they never attended programs, but the majority, 37%, were attending programs once a month, and less than 20% were attending programs at least once a week. So there seems to be fairly infrequent program attendance, if at all. And then when we asked them about travel, almost 70% of individuals said that they had to travel outside their neighborhood in order to attend a health promotion program or event. And so that makes us wonder then, are zip codes, are the specific neighborhoods within this study, sort of providing the resources they need for those individuals? If an area is highly programmed, would individuals from other regions go into that zip code to attend those events? And so it sort of raises more questions than it can answer. And we found that in 19801 and 19805, there was no statistically significant difference in the total average of the program availability, the program need, and the program usage. And our numbers actually suggest that there was pretty high program availability in these areas, and individuals were also taking advantage of these programs. So those numbers are pretty promising.
In terms of limitations, just really quickly, we had a small sample size for the survey as well as the corner store evaluations. It was also a convenience sample, and we had some issues with accuracy in reporting responding, because how do we know that these community members really understood our survey, and how do we know that they were really just answering the questions to the best of their ability when they thought about program availability. And this is also the pilot phase of the project, which Maggie will touch on now.
Hey, everyone. I'm going to be really quickly because I know Dr. Fagan is giving me a quick timeline. But my name is Maggie with Westside Family Healthcare, the community partner. But this is really a collaboration between the Delaware Center for Health Innovation, Westside, to support two great students, Alexa and Jackie, who are actually graduating in just a few weeks. So were fabulous students to work with. One of the big future directions that this information was presented in August to the Healthy Neighborhoods Committee, and really it was utilized and leveraged to create a data committee that is going to support all of the efforts, really pulling experts from UD, the Excel program, Christiana, the state epidemiologist, to really look at healthcare data in very different parts in different ways. And then this information is definitely going to be used for the local council in Wilmington, which I'm a member of on behalf of Westside, to help us determine where to start first and what communities and what areas can we start to collaborate and really move the needle in some of the health challenges that we face. But I want to say one quick note. I'm sorry, Dr. Fagan, but I really want to commend Alexa and Jackie. They are seniors, and they were at the time juniors doing this research and took it and ran with it. And I really congratulate them, and I know they have a bright future ahead. Thank you, guys.
Right in the middle of the room there.
This is a really great project. Thank you very much for presenting it. What type of? I'm intrigued by the chronic disease management programs that you talked about. What type of programs are they? What type of program did you find? Or
They were a range. So one of the big things that we started with was just trying to kind of pull it together, a database of anything from a diabetes case management program to healthy active living. It could be a senior center, kind of what our colleagues presented around art of happiness. So anything that is related in the scope to disease prevention and also healthy living. Does that help?
Yeah.
Okay.
Absolutely. I have another question. Oh.
There's, I think, someone behind you.
This is great work, and like Heather, Claymont is a place that's near and dear to my heart as well. So, question for you about the size of the geographic areas that you were looking at. So, one of the challenges with any geographic study is getting an area that's large enough so that you have enough information to make it usable and interesting, but small enough that it's actually practical and usable for the programs and people that are in those communities. And one of the interesting things here is the joining of Claymont and Wilmington into the same sort of the same bucket. So do you have any thoughts about whether zip code is the right area to look at? Should we be looking smaller, larger, and any challenges or opportunities you see?
I'll go ahead and answer that question. That's a great question. And there's actually a lot of, good amount of committee members. Dr. Khan is one of them. Brian's here that actually are members of the Healthy Neighborhoods Committee. And it was something that was decided, and I will kind of fact check a little bit over with Dr. Khan, but a couple years ago when the state received the SIM grant, the idea was to have a neighborhood size that was large enough and big enough and vast, and the idea was to try to keep them relatively consistent between 90,000 and 100,000 residents. And that's essentially why Wilmington and Claymont was connected, because of the trying to reach that quota. But it is very well, over last several years, been talked about that Claymont is very different than west side of Wilmington, and there's a big distinction. And that's something that the Wilmington-Claymont Council on the local level is talking about, and really kind of narrowing down that sometimes a strategy or intervention might work really well at Claymont because of the resources that are there, and may not work, that same intervention may not work well in Southbridge. So that is definitely in consideration. Questions?
Wonderful. Well, that was another terrific round of presentations. So I want to give a special thank you again to our pinch-hitting leader, Dr. Bittner-Fagan, who jumped in. So thank you, Heather. So I know our next speaker is going to have some thoughts about the community health and public health implications of all you've heard today. So it's a real treat to introduce to you or reintroduce to you Dr. Kara Odom Walker. Dr. Odom Walker was sworn in as our Cabinet Secretary of Health and Human Services in February of this year. She has previously served as Deputy Chief Science Officer at PCORI, the Patient-Centered Outcomes Research Institute. Prior to that, she was a family medicine faculty member at the University of California, San Francisco. She is a local Delawarean, as several of you know. She went to high school in Delaware, went to the University of Delaware, right here, went to medical school at Jefferson Medical College. We briefly shared an alma mater at the Johns Hopkins School of Public Health. She went out to California after that, where she's been ever since. Today is also a little bit of a reunion for her with her colleagues, Dr. Bowen Chung and Dr. Loretta Jones, so we're pleased to help make that connection. And we're really looking forward to hearing Secretary Walker's thoughts on how this work that we all are doing within Excel interfaces with the work that the state is doing on several of these same areas. So please join me in giving a warm welcome to Secretary Kara Odom Walker.
Thank you, Dr. Khan, and thank you to all of you for being here. This is just such a wonderful opportunity to talk to you a bit about both my experiences at PCORI, but also how all of those experiences tie together to really get more evidence into practice. I also just can't tell you how warm my heart is that Miss Loretta Jones is sitting in the audience today. She molded me as a young researcher who was really trying to figure out how to work with a community of South Los Angeles, a community that's as big as our state of Delaware, 1 million people, mostly African American, Latino, and they were really trying to figure out how to address structural issues in healthcare and reopen a community hospital that was being shut down for many political reasons. But she made such an impact. I would sit with her evenings, weekends, and she would just school me on what it meant to be a true community partner, where the community had a louder voice than the academic or the policymaker. And I still carry this key. In fact, I told the story of the key at my first day on the job at the Department of Health and Social Services, right, Secretary Landgraf? Because she made such an impact on where I see my role in really opening doors and speaking on behalf of others who may not have a chance. So I'm just going to tell you a little bit about my view of what it's like to be a PCORian, as they told me when I left. I was employee 21 at this little place that was a political landmine from day one, where people were already debating whether it was going to create death panels, remember that? Or what the opportunity would really be to have evidence that helped decision makers. But I have to say, we were creating things. I was part of a startup. We were working all day, all night, all weekend, trying to just figure out simple things like how we would take in applications and how we would review things, how partners should be defined and engaged in research. So this curve, I love this. It really was an emotional journey at PCORI. It's a little bit about like, I got there, I was so excited. We were all so excited. We felt like an army. We're like, we are gonna do this research thing differently. We're gonna figure out how to incorporate engagement in everything we do. And then you sort of said, well, this is really hard. Trying to figure out what it means. And there was certainly this low point of where like, what really are we doing? This is not working the way we want. Politics and stakeholders were saying, you know, are you doing enough here? What are you really doing with your $2 billion? Are you doing it in the right way? And then I have to say, when I left, I felt like this was the best thing and the best experience that I could have ever opted for. We were really trying to figure out how to do things differently. And that conversation, as many of you know, has really changed what we're doing in terms of using evidence generation to engage patients, engage partners, and move that paradigm of having data and real evidence take less than 17 years to get into practice. I have to say, from where I sit now, I just started in February, it's still taking a long time to get evidence into practice and into policymakers' hands. Sometimes it's not evidence that makes a difference, it's the anecdote. And sometimes it's having the right policymaker make the right phone call, or that patient story really make a politician have their heart compelled to make a difference and allocate a budget in a different way. I have to say, this is a very true curve, and so I'm really pleased to see it from both angles now. I was asked to talk a little bit about PCORI because I do think, even now in my role, it is a really important framework for how we're going to do things differently. Now, we don't know what's going to happen with PCORI, right? The political environment is shifting. Their funds actually are going into the trust fund until 2019 and will be spent out till probably about 2025. So if you haven't applied, apply now. Get those dollars before they're gone. They may get a new bill, but who knows? It's going to be a bit of a political process. This organization was really created as an independent organization and funder with dollars from Congress and a board of governors who actually took on engagement because of a mentor of Ms. Loretta's, Mr. Eugene Washington, who decided that they were going to take this principle that was laid out in the legislation to fund comparative effectiveness research that engages patients and consumers along the way. There's nothing in the legislation that says the word engagement. There is nothing besides the name that says patient-centered. It really was just a chance happening that someone called it the Patient-Centered Outcomes Research Institute, and that people serving on that board decided that engagement really matters. And obviously we know this is still a hypothesis. We're figuring out how it matters, why it matters, but I know for all of you who have worked with community partners, you know it's making a difference. So I think PCORI's goal of trying to use real-world evidence to inform decisions that patients are making every day with their clinicians, with payers, will really make evidence that's more useful in the end. So they're trying to get there. This is just a quote from the legislation. It really is fascinating that they threw in this overarching goal that was talking about assisting patients, clinicians, purchasers, policymakers in making better informed decisions by using evidence that's generated. They also are talking about how to create a dissemination pathway, and for any of you who do have PCORI funds, you know that there is a goal to make sure that all of that information is both publicly available as soon as possible, but also digested into a shorter way that is consumer-friendly, and they're really trying to commit to that and stick to that mandate. But ultimately, PCORI was set up to increase the value and reduce waste in research funding. And for any of you who have seen this information, a lot of people say that research is creating a lot of work. And some people say that as much of 85% of research funding is actually wasted. Now, I have to say, for all of you who have made your life's career, as I've spent a long time in academia and on that academic pathway, it is very hard work to make that work meaningful, right? And to get it into the hands of people who will use it. But I think that if you think about this framework to really pull questions that are meaningful and that you get it in the hands of people who are going to use the evidence at the end of the day, the principles of engagement, the principles of innovation, acceleration, and translation, that is the strength of engagement, and that is the power of having people who are going to use the evidence involved at every step of the way. And I'll have to say, sitting next to Ms. Loretta, she's not quiet if you get a chance to talk to her. And she will tell you, where are those community partners? Where are they? Are they making the decisions, or are those academics? She would keep us straight. And that is what you need. You need a voice in the room when you're making decisions about one instrument versus another, about what the end product will be, whether it's a paper, a white paper, a presentation to a politician. You need those people at the table helping you really define community and define whether you're going to use that evidence at the end. That's how we make those research dollars matter. That's how the work to really create infrastructure in communities can make a big difference, because it's not only about funding the next publication, but really how do we use those resources effectively. Engagement at PCORI was something we just lived and breathed. It was about how you get people at the table throughout everything we do. In fact, we had one of our second largest department was completely dedicated to engagement. But it was about how you get questions in that are from the people who will use it, from patients and consumers. It was about how do you get patients at the table selecting and reviewing the applications. It was about how they've written in every single application the dissemination and implementation pathway, right? It's, are there patients who are ready to use this? Are there stakeholder groups who are asking for this information? Are there policymakers or payers who say, we really don't know which is the best treatment versus another? And then at the end of the day, we all need this cycle that says, are we doing a good job? But if patients and consumers and stakeholders and payers are telling us PCORI's doing a good job with that $2 billion, we hope that that 85% number will shift to something that makes much more sense. So we know, all of you know, that engagement feels good once you have it right. It might be a struggle at the beginning when you're trying to figure out who those partners really are and how you define partnerships. But we also know that from a systematic review, engagement can really enhance the quality and the appropriateness of research. It's not about asking questions that may make a difference. It's about knowing that that is truly going to make a difference, whether you have an answer that's answer A or answer B. So we still have a lot of work to do, and certainly PCORI's portfolio will be a great test case to see whether engagement is making a difference. There are some early signals that indicate that that work is going to be more rapidly used, and but the path to uptake is long, and it certainly is a real issue. I have to say, again, this key that I carry around is a very true reminder, right? We're very good at saying, where's Waldo? You know, we have all these survey instruments about quality of life and whether people are doing well, but you also have to start with the simple questions of how's Waldo? Nobody ever asks Waldo that, so he looks a little sad. But that's what patient-centeredness is about. That's how we get there. I mean, what we want is an evidence base that is as simple to digest as a consumer reports, report on picking a washer. Now, I have to say, I know as a physician, sometimes when I have these conversations with patients, it's a little bit different depending on what insurance they have and what their circumstances are, what other comorbidities they have, right? But I could imagine those as rows on this slide, right, where each of those washers is a pill or a treatment or a surgical option. We have a long way to go in medicine to get to something that's as easy to understand. But that's the goal of comparative effectiveness research, so that we really have evidence that compares in an even way, in a trusted way, that you can really make an informed decision. And it may not be the right decision, washer A for everyone. It really may be something you have to think through. This is why people called for comparative effectiveness research a long time ago. They really wanted more studies about these practical, everyday decisions that clinicians, providers, patients are really making every day, but we don't have good evidence. And we don't know what the best choice is given a person's circumstances and situation. We also know that we have a huge gap in evidence. And even when you look at something like the clinical practice guidelines, most of it is based on anecdote. Most of it is based on expert opinion. We actually only have level A evidence, gold standard RCTs, about 11% of the recommendations that are out there. That's surprising when we think about how huge the research engine of NIH and other funders is. We just aren't able to get those right questions into guidelines quite yet. But I hope this group, and through working with patients and stakeholders, we can make that number go up higher. But it is expensive work. We also know that there is huge variation in practice, and I know that even just from looking and zooming in on California or Pennsylvania or in Delaware, and for those people who are working in clinical settings, you know that depending on where you work, sometimes there are just different standards. There are different ways of practicing, but it actually does link to poor patient decisions. And that's where we have an opportunity to really infuse evidence into practice, whether it's through checklists or prompts that are built into the electronic health record. We have an opportunity to change that. And certainly in my role now in the state of Delaware, I feel a strong commitment to making sure that we're improving quality towards high quality outcomes that are really keeping patient-centeredness at its core. But, you know, we need to have better conversations about what the benefits and harms are, and certainly CER is trying to get there. You're trying to figure it out in real-world populations, not just in the gold standard RCT where you have a very defined eligibility criteria and a very defined protocol. That's not the world our patients live in. We really want to figure out evidence that's going to inform a specific clinical or policy decision, what we call a decisional dilemma. Certainly, now in this role, I want more evidence, and I hope you'll send me that evidence of what could really help me make better policy decisions and recommendations to the bodies that be, because that's where the value of research and partnership really comes in. And certainly for patient-centered outcomes research, it is about that question of not where's Waldo, but how's Waldo. You know, we really want to know the patient-centeredness, the preferences and needs of individual patients. We want to make sure that everyone's able to make more informed decisions with a conversation about what's right for those individuals. The goal of PCORI originally was really to fund more studies like this. For some of you, you may know this all-hat study was a huge study. It actually cost about over $100 million. And it was a huge RCT, really looking at this question of what should be first-line hypertensive therapy. It was thought that this was just a simple thing we should really know, and they recruited over 30,000 participants to answer this question that now we know the answer to. At the end of the study, they realized that thiazide-type diuretics are superior in preventing certain types of coronary vascular disease and are less expensive. In fact, they should be preferred not only because of cost, but because the outcomes were better. Then when they looked longer term, you actually realized that the costs were even reduced over amlodipine and lisinopril. And adding in quality of life, it didn't change the results. Now, if PCORI could fund more all hats, they probably would have. They weren't given enough money to do much of that. $2 billion, $100 million. You know, they really just decided to fund many pragmatic clinical studies rather than invest in this type of dollars. There are very few places, even funded by pharma, that are actually looking at large-scale CER studies. We need more evidence like this, and I must say, we'll have to figure out how to get there in a cheaper, faster way. But it is fascinating that this huge study helped us define better guidelines. It provided better information on the harms and benefits of these three antihypertensives, and it let us look very closely at which therapeutic option was best for certain age groups, which we still use this evidence today. We're actually, instead of chlorthalidone, we're using hydrochlorothiazide, which many of you probably are more familiar with. But, you know, we know what to do with these subgroups. We need more evidence like this so that we can get to a place that we're talking and having a conversation that includes all of the factors, all of the things that define who I am and what my circumstances are, but you can make a more informed decision and have a conversation with your clinician. We still have a ways to go, and we're hoping that CER and more engagement in research will help us get there. Certainly, over time, this name patient-centered outcomes research is changing the conversation among researchers and clinicians. Certainly many are starting to include more patient-centered outcomes in research and extending this model of engagement to policy and social determinants of health. I think you heard some of the work today really is showing that we're using that term more. We hope that we're not only using that term, but we're really starting to embrace it, to make it part of our everyday approach to doing research and make it more useful for more players in the healthcare sector. But we have a lot of work to do. Certainly, the other piece of this is flowing important questions and priorities from funders and others who are doing this work into relevant work and practice and policy. And I'm on that other end now, and certainly I would love to know confidently I'm always going to be in a situation where I have evidence guiding the decisions and the conversations. We have a ways to go, and I hope that this community can embrace that and also make sure that our funding community, those who are paying for the research, continue to keep this at the forefront, because it is really critical to making informed decisions for practice and policy, whether you're an insurer, a policymaker, or someone developing new programs. you know, this is where I am now. I'm sitting in that little yellow box where I'm looking at these issues around clinical and healthcare policy, but certainly we all have a role in making sure that the funding is helping this entire cycle. Not only NIH and industry and academia, where a lot of the discovery work is going on, but we also need to talk to our partners who are on the regulatory side, who are looking at drugs as they come out, CMS, who's trying to decide what evidence is needed in order to document something as an approved and paid for therapy. We also need PCORI to keep going and look at comparative clinical effectiveness. How we continue to do this work and where it sits will be really important. But certainly, now that I see more of what goes on with the payer scene, with the insurers, you know, you read in the headlines, Aetna's pulling out. It's because of the intersection among all of these groups of what's going on, the influence of drugs and the choices that people are making about one drug versus another. One may be much more expensive, but we don't know if it's effective yet. Those things have direct ties to what's going on in the clinical and the policy space. So I'm looking forward to ongoing partnership. Certainly our department has a welcome doormat out there for any researcher who wants to look at programs that are currently funded by us in communities that you're working in already, whether it's Wilmington or Claymont or down south, or with the aging or disabled. We certainly have programs and have funds already committed and staff already committed to working on important issues that we could be a natural partner, and I hope many of you will take me up on that offer going forward. So thank you for this opportunity. It really is an honor to be with all of you today, to bring my perspectives, and to also get to know many of you in the room. Thank you, Dr. Khan, for this opportunity. I hope you'll have time for a couple of questions.
Hey, Kara. So one of the things, I talked to a lot of, elected officials and legislative staff at different states and federal government, and a common thing that comes up with the community, and this is a tension that I feel as a researcher, is that there's a lot of community-defined evidence, whether it's in public health, especially mental health in the area that I work in, for peers and other things, which doesn't have a lot of scientific evidence, but has a lot of, how would I say, community-based validity over years and years. And there's a lot of funding for this. And how should we as a researcher or somebody working with the state and maybe communities still trying to learn that, sort of think about how to approach these things? Because one of the things that I've always been struck about science is that things may not work even if you measure it correctly, the way it's intended. And there are some consequences both ways, an impact on funding and what people believe.
Yeah, I appreciate that. And I think the peer navigator, health coach space is growing. Certainly at PCORI, about 40% of the portfolio in the disparities area was all dedicated to the growing evidence needed for peer navigators. I think that there are more entities, health systems, payers who are committing dollars to develop exact appropriate programs that will really support patients, and they go by all different names. I mean, you've heard them. They're peer navigators, health coaches, promotores, they're all kinds of names. But I think that, there are real needs as we move to value-based payments to have a payment system that's aligned. And the better we have evidence, stories even, papers that can tell that story, I think it will make a tremendous impact. I think that sometimes in that space, there's a gap between having real comparative effectiveness data and having cost effectiveness data. So I've seen a few studies, but I think that that is probably where we have to go next, because if you could have a sort of systematic review of how it's made an impact in diabetes and CHF and other chronic conditions, it may be something that the payers could help us really integrate.
true.
publication or societal. And presumably state, local, and federal government is supposed to take that perspective. But, you know, it's hard, unless it's, you know, some direct budget category, it's hard to sort of make an argument for something from societal.
Yeah, no, it's true. Although I feel, I mean, I don't know. Again, this is my second day on the job. I had to present the department's budget, and so I did my best. But they asked, like, what are the outcomes you have for all of these programs? And I was presenting the budget. So if I could make that case in a stronger way, that would be incredibly helpful. You know, that's my experience here in Delaware. I'm certain it's going to start happening in other places. Thank you, Bowen.
In South Carolina, we hear from our communities, particularly the under-resourced communities, that we need to spend more money on getting the evidence into the community versus new research. So my question to you is, how can the public health departments and the academic institutions work together to do more dissemination and implementation research?
Thank you for that question. So I think that the dissemination and implementation research question is really hard. I mean, PCORI had funding set aside, and certainly the Agency for Healthcare Research and Quality has funding set aside to do dissemination work, but it's not around public health issues, and I think that's the gap. I mean, we can always say entities are going to partner, but without funds and dedicated staff time, it makes it very difficult. I think that's why we have to just embrace that the engagement piece has to be part of everything we do, because that assumes you're going to do the dissemination from the beginning. You're going to work together to create that message and the pathway that is appropriate for whatever community you're working on. And aside from that, I think we have to continue to work with the translational research paradigm so that we can say you're taking the evidence and you're moving, you know, you're funding communities who are ready to create a pathway for uptake. But I agree, it's probably the hardest thing and the thing that the research community has the biggest struggle with, because we, you know, the academic paradigm is get it published, right, in an academic journal. Well, probably all of us can't even keep up with those publications because it's just so much out there. But I hope we can think about innovative ways to really work on that issue in a consumer-friendly way in particular, too.
Hi, really very much enjoyed your talk. Thank you for being with us today. I had a question similar. There was recently a call, I think it was in Health Affairs, for more comparative effectiveness research specifically aimed at the social determinants of health. And that really challenges us to get out of our more traditional medically focused interventions. Even health coaches is, I think, I would categorize more in that medical focused one at a time approach. And I've long thought that here in Delaware we have a unique opportunity because we can talk with government officials, policymakers, we have the academics, we have the community partners. I wondered if you might say something about how we can move forward in that direction as a state and through partnership maybe with Excel.
Yeah, no, I love the idea. And I think that was one of the reasons why I was so excited to come back to Delaware, because it is a very unique landscape where we can get people in a room and have a conversation, but we've also invested incredibly in the Delaware Health Information Network, where, you know, maybe not yet, but we should be able to have the technology to have social determinants built in, where we're having more conversations about trauma-informed care and having real screeners kind of built into the typical clinical environment, and then create these, you know, pragmatic studies where you're able to look at information that's already in the clinical setting, but do a randomization, right? Because we have that capacity. It's really just about leveraging the existing researchers, and those can be done pretty cheaply. You know, for $1.5 million, you can do a huge study with a lot of people. In fact, we could probably do it with huge segments of our population, you know, looking at health disparities issues, looking at health equity, and I would love to explore other ideas, but definitely it seems like if anybody could pull it off, it's our state, so we should be able to figure it out. Am I getting the hook? I know I'm between you and lunch, so.
You can stay as long as you want.
Well, I look forward to having more conversations with everyone and hope we will have that opportunity. So thank you for all your work.
Well, thank you, Secretary Walker, for challenging us to do exactly, I think, what Excel is meant to do, which is move information along the arc of evidence and information and ultimately policy, which affects all of our colleagues and our patients and our population's lives. So thank you for the challenge. And likewise, as you continue in your role, we look forward to hearing about your legislative priorities and how this arc can help you move the state towards a healthier place as well. So thank you for that.